Hello everyone, today we will discuss bronchopulmonary dysplasia. This bronchopulmonary dysplasia is also known as chronic lung disease of prematurity. Okay. So starting off with its definition, this occurs in the preterm infants who require mechanical ventilation or oxygen therapy for their primary lung disorder. Okay. So in definition, when a premature infant, of less than 32 weeks of gestational age with BPD is said to have BPD when the child has a radiologically confirmed parenchymal lung disease. So premature infant with BPD has a radiologically confirmed parenchymal lung disease and along with this, the child when he or she at 36 weeks of post-menstrual age requires O2, requires oxygen concentration for more than or equal to 3 consecutive days to maintain the saturation, that is SpO2 between 90 to 95%. Okay, this is the definition of bronchopulmonary dysplasia. So a premature infant of less than 32 weeks of gestation is said to have BPD when the child has a radiologically confirmed parenchymal lung disease. Along with this, the child when she or she at 36 weeks of post-menstrual age requires oxygen concentration to maintain his or her saturation to between 90 to 95%. This is our definition of bronchopulmonary dysplasia. Next we'll go into its diagnostic criteria. Okay. So next is the diagnostic criteria. So in this diagnostic criteria is taken from our Avery's textbook, okay, of newborn. So first is treatment with FiO2 of more than 0.21 for at least 28 days. Along with that, the child will have a failure of room air challenge test. The child will have a failure of room air challenge test at 36 weeks of post-menstrual age. This was our definition because the child was not able to maintain the saturation in the room air between 90 to 95% at 36 weeks of post-menstrual age. So these are the must required criteria. Okay. So the treatment for the child with the FiO2 of more than 0.21 for at least 28 days. Along with this, child cannot maintain the room air saturation at 36 weeks of post-menstrual age. Next is classification of their severity. Classification of severity. It is classified as mild, moderate and severe. So you tell it as mild BPD when the child requires less than or equal to 0.30 effective FiO2. That is when the child requires FiO2 of less than 30%, you call it as mild. Moderate is when the child requires more than 0.30 of effective FiO2, you call it as moderate. You call it severe when the child requires a ventilatory support with oxygen therapy. Okay. So this is the classification of the severity of BPD. Okay, next we'll go into its pathogenesis. So here we'll cover pathogenesis, its pathology. In pathology, they will classify it as old BPD and new BPD, and we'll see its management. So next we'll go to its pathogenesis. So this BPD is multifactorial in its etiology. So it is mostly multifactorial in etiology. So the most important etiological factor or pathogenic factor that is required for the BP to occur is prematurity. Okay. Next, other risk factors. So what are the other risk factors or the etiological factors that can be involved in a child with BPD? First one is continuous oxygen therapy. Second, mechanical ventilation. Third, when the child has a co-infection. Fourth, genetic predisposition. Fifth, when the child has a PDA that is going in, or PDA has complicated to a pulmonary edema. So these are the other important risk factors can contribute to the pathogenesis of bronchopulmonary dysplasia. So when the child is premature, child is requiring oxygen therapy through mechanical ventilation, or child has got a co-infection along, so everything will all lead this to lung injury. Okay, this all will lead to lung injury. It can be ventilator induced. When the child is on mechanical ventilation, this can be due to ventilator induced lung injury, whether it can be due to Breuer trauma or Valier trauma. Next, when there is an injury, what takes place? There will be a inflammatory changes, that is there will be a neutrophil influx and also macrophage influx. So there will be a neutrophage and macrophage influx. This can lead to increase in the pro-inflammatory cytokines. So that can lead to increase in pro-inflammatory cytokines. This everything will lead to, first, surfactant dysfunction. So this first can cause surfactant dysfunction. Second, it will cause failure of alveogenesis, because it is a premature lung. The child will be only in the third stage of their lung development. The alveogenesis will not have been taken place. So there will be a failure of alveogenesis. Third, there will be an increased airway and vascular resistance. Increased airway and vascular resistance. Fourth, there will be this everything will lead to an abnormal repair of the lung. So when there is an injury, there will be a repair that can lead, but here there will be an abnormal repair. So in this abnormal repair, there will be a increase in elastin deposition. Okay, there will be a elastin deposition. So this everything will contribute to BPD. Okay, understood? So when the premature child on oxygen therapy or mechanical ventilation have got an infection, or the child has a PEDA which has led to pulmonary edema, this everything will contribute towards lung injury. This can cause the influx of neutrophil and macrophage, which can increase the pro-inflammatory cytokines. When there is an increase in these cytokines, there will be a surfactant dysfunction, failure of alveogenesis and abnormal repair. This everything will lead to bronchopulmonary dysplasia in the infant. So this is the pathogenesis in bronchopulmonary dysplasia. Next we will see its pathophysiology or pathology. In pathology, it has been classified as old BPD and new BPD. Old BPD is severe form, is called as old BPD. New BPD is a milder form. So first we will see about this old one. So here, when the child has received an aggressive ventilation, when the child has been exposed to high FiO2 concentration, so this everything will lead on to its morphological changes in the lung. So what are its morphological changes? So the child can have emphysema, second atelectasis, third fibrosis, and fourth there will be a marked epithelial metaplasia and smooth muscle hypertrophy. The smooth muscle hypertrophy will be present in both the airways and in the pulmonary vasculature. So this is the morphological changes when the child has been exposed to a high FiO2 with an aggressive ventilation, that is severe form of BPD, that is also called as the old BPD. New BPD, it is a milder form. Why it is a milder form? Why? Because here this occurs to an infant who has been exposed to a corticosteroids. So this occurs in infants exposed to steroids. So the child will have, so when the mother, when you are expecting a premature delivery in a mother, you will give a steroid dosage to the mother. Antenatal steroid will be given. This was antenatal steroid has been covered in the previous videos. So when the mother has received a steroid dosage, the child can have a mild respiratory distress. There will be only a minimal respiratory, that child will require only a minimal respiratory support. Okay. So when there is only minimal respiratory support, there is no need for a high FiO2. So the pathology or the morphological changes will also be reduced in this child. So the morphological changes that this child can have are, there will be a decrease in alveolar septations. Second, there will be an impaired vascular development. There can be, these changes are more due to a arrest in the lung development than a mechanical injury. While in the old BPD, these are mostly due to a mechanical injury, while these are due to arrest in the lung development. Okay. So these are the pathological changes in BPD. Next. So what are the clinical features the child can have? The child can have respiratory distress. So the child will have its breathing as fast and shallow breathing will be present. Second, the child can have retractions. Third, the child will have a paradoxical breathing. Fourth, the child will have wheeze and crepitations on auscultation. Okay, so these are its clinical features. Next we will see its X-ray findings. So what all will be the X-ray findings? Here also we will classify it as old BPD and new BPD. In old BPD there will be 4 stages. Okay. So here in stage 1, it will be a consistent with hyaline membrane disease. So it will look like hyaline membrane disease. Second, the child can have opaque lung fields with air bronchogram. Third, the child will have a small radiolucent fields. Fourth, the child will have a hyperinflated lungs with generalized cystic areas and fibrotic stents. There will be a hyperinflated lungs with cystic areas and fibrotic stents. In new BPD, the child will have only haziness. So here the child will have haziness. So this haziness reflecting a diffuse loss of lung volume. This haziness reflects a loss of lung volume, or where there can be an increased lung fluid. Okay. The child can also have a segmental or a lobar atelectasis, but there won't be any hyperinflation. While in old BPD, the child will have a hyperinflated lungs, while in new BPD, the child will not have any hyperinflation. Okay, this is about the X-ray findings in child with BPD. Next we'll go on its management. Management part, it is classified as to prevent BPD and to treat the establishing or established BPD. So the treatment part will be big here. First we have to see the management for prevention of BPD. So I will tell only the gist for this, okay. So management, only the gist, that is the topics, mostly the important points I will tell. So you can write all the inside points from this main topics, okay. So the management will be of two, that is to prevent BPD. Next is to treat the establishing BPD or established BPD, okay. First is to prevent the BPD. So prevention at the before birth. How are you going to prevent? You have to prevent the prematurity. How are you going to prevent the prematurity? By giving antenatal corticosteroids. Before birth, that is, you have to give a antenatal steroids to the mother. This antenatal steroids will prevent, this can prevent the neonatal death, or it can reduce the incidence of RDS, but it cannot reduce the incidence of this BPD or called chronic lung disease. Okay, this is before the birth. Next, after birth in delivery room. So in delivery room, the most important thing is golden hour of management. So the principal management in the golden first hour. In the golden first hour of the management, what are you going to do? First, you have to establish the functional residual capacity. In golden hour, you have to first establish the functional residual capacity. Next, you have to improve the pulmonary blood flow. Third, there should be a adequate tissue oxygenation. You have to ensure there is an adequate tissue oxygenation. So for this, what are you going to do in golden first hour? To establish this FRC, that is functional residual capacity, you have to provide adequate PEEP. You have to provide adequate PEEP to the infants with respiratory distress. For providing adequate PEEP, you can use TP's resuscitator, or you can use an early CPAP, that is delivery room CPAP can be used, followed by selective use of the surfactant. That is, the surfactant is not used for every child. It is mainly used for selectively you are using the surfactant. That is selective use of surfactant. So early CPAP with selective use of surfactant. That is the main thing here. Next, third one, there should be a restricted use of oxygen. So restricted use of oxygen meaning, in a term child, when you are resuscitating a term child, there can be FiO2. You have to use the FiO2 of room air, that is 21% is enough. In a preterm child, FiO2 that is used is 30%. So this is the meaning of restricted use of oxygen, and that is the room air oxygen for the resuscitation. Or you can use a time targeted oxygen saturation during the resuscitation. Okay. Next, in NICU. This is in the delivery room. Next, in NICU, what are you going to do? First, fluid restriction, fluid and nutrition. So fluid restriction. So in preterm infants, how are you going to start the fluid? On day 1, you have to start with 80 ml per kg. On day 7, it is 110 to 130 ml per kg. Per day, how are you going to increase? So the daily increment will be 15 to 20 ml per kg will be the daily increment. This is used in infants whose birth weight is less than 1500 grams. Okay. Next, fluid restriction, one is by using this method. Second, you can use plastic wraps. The plastic barriers, that is the cling wraps, are being used. That is, it covers the what is called basinant or the vomit. It covers the vomit, so that can decrease the insensible water loss. Second is nutrition. Nutrition is early transition to enteral nutrition. There should be an early transition to enteral feeding. Okay, so parenteral nutrition is continued till the oral intake reaches 130 ml per kg per day. Okay, next, third will be ventilator strategies. Ventilator strategy, proven benefit is when you use volume targeted ventilation. Okay, possible benefits is found when you use a early CPAP or when there is a patient triggered ventilation is being used. Third, you can maintain a permissive hypercapnia. Fourth, permissive hypoxemia, that is you can maintain the saturation between targeted saturation between 90 to 95% until 36 weeks of post-menstrual age. Okay, then you can use a high frequency ventilation, that is HFOV can be used. These are the possible beneficial effect that can be done in the ventilatory strategies. Okay, next is pharmacological. What are the drugs that can be used? So pharmacological strategies, initially it is exogenous surfactant, that is selective use of the surfactant should be used. So I will discuss about surfactant in a different topic. Second, you can give vitamin A. Vitamin A is given in a large doses as IM injection. It is given at the doses of 5000 international units 3 times a week for 4 weeks. Okay, from the birth. So this can decrease the risk of BPD, vitamin A. Next, use of caffeine. So when the caffeine is being used, it can decrease the stay of the infants in mechanical ventilation. Next, there is a try of this postnatal steroids. So when the child, the infant weighing less than 1500 gram is being in a ventilatory support for 10 to 14 days, you can try this low dose dexamethasone. Okay, that is called as DART regimen. So DART regimen is nothing but dexamethasone or RCT trial. Okay, so this is about the pharmacological strategy. Our last one is diuretic therapy. Diuretic therapy is used when you find the child with the symptoms or signs and symptoms of pulmonary edema. You use this diuretic therapy. So this is about the treatment options or pharmacological options for a child with BPD. In next topic, I will cover this treatment of this established BPD and this evolving BPD. That is very small one that we can cover it in just 10 minutes time. Okay, and thank you. Please like, share and support our YouTube channel. Let's all learn pediatric together. If any doubts, please refer to our this Telegram group, that is PEDS University Exam Discussion Group. I'll post this PDF in this Telegram group. Okay, thank you.